Good morning. I think we will start. Welcome to this morning and early lunch session on WatchPAT sponsored by Itamar. This symposium is going to be in English because, first of all, the company is an international company. On the other hand, we will have 3 speakers, sleep specialists, and 2 of these speakers are non-native speakers coming from Israel and Sweden, and that's why we are going to talk in English. Well, you all know that obstructive sleep apnea is a common disorder, and it's relevant due to its high cardiovascular morbidity and mortality and decreased daytime sleepiness with all the consecutive risks associated with that. Therefore, early diagnosis is essential, and one of these devices to diagnose it early in the ambulatory setting is the WatchPAT device. And first talk will be given by Jan Hedner. There's a switch in the program, and he will talk. He's from Gothenburg in Sweden and has a big sleep lab, and he will talk about total sleep versus total recording time in home sleep testing. Yeah, we're glad that you're here and are interested in your talk.
Thank you very much, Bernd. I think you're happy that I will not be speaking in Swedish, so at least we make it a little bit easier if I do all this in English. First of all, I'm very happy to be here. I'm grateful for the invitation, although the label of my talk is a bit more complex one. I think it sounds a bit cryptic to you, and it was cryptic to me. What does this really mean? Total sleep versus total recording time in home sleep testing. Well, it really revolves around the application of the technology. So this will be my topic. I should start with, I guess, giving my disclosures, which are none. I'm not paid for this talk, nor am I paid for the trip here for my Itamar. I'm simply very interested in this technique, which I think is a very interesting one to develop. So I will ask a couple of questions as we move on, and then we'll see to what extent we can respond to those questions. The first thing is, or the first question is really, what are the characteristics of this PAT signal, and what is this? What does it mean? What does it measure? What do we assess? Well, first of all, I think it's a very interesting spot to be on if you want to assess something that's changing, especially something that changes your arousability in the body. So if you go to the finger vascular bed, it's interesting due to its high density of anastomosis. So these are arteriovenous anastomosis, which means that we can shuffle a whole lot of blood through the circulation without really going through the capillary system. And this also means that we can have a huge variation in the degree of blood flow that we get through the finger's vascular bed. And so you can see some numbers here, is that if you measure or assess this, you could have numbers anywhere between 1 and 90 milliliters per minute or 100 milliliters of tissue, which is a 90-fold change of circulation, which of course is physiologically very useful when we tend to either save heat or get rid of heat. The other thing is that if we're going to regulate this area, if we really want to switch all this vasculature and change the circulation through it, we need a dense innervation, and this is certainly the case here. We have a very dense innervation, which is the very basis for the technique in itself. And there have been a number of studies going on throughout the years. This is from Peter Catcherside in Adelaide in Australia, who looked at different types of arousal signals and how well these arousal signals could be reflected in different types of autonomic signals. So what all these quite complex graphs, what they really show is that if you want to measure an arousal or a change of state, and correlate that with conventional EEG arousals, you could measure, for instance, heart rate changes. You can measure skin blood flow changes, the pulse transit time or pulse wave amplitude changes, and you can see that this latter one is a very strong predictor, and it's actually sort of dose dependent in the relation to arousability. So the first issue here is really, yes, what happens in there is an arousal that's happening, and when the arousal is happening, there is a massive change in this blood flow through the finger. So the technique here, in a sense, is a basic plethysmography. You can get part of this signal simply by doing an oximetry sensor, although the PAT technique has a couple of advantages, because, as is shown at the bottom here, you apply some constant counter pressures, you get less of blood pooling, you get a far more stable signal without drifting with these specific techniques. And the probe itself, I think many of you may have seen, or there may be opportunities to take a look closer into that while we use it here. We've been looking at, I guess, through the years on a number of these devices during the parallel with development, and this is an early one, which was a bedside device called the PAT 200. And we used that to look a little bit closer to this vascular signal. So if we now think that this is an autonomic signal that changes the flow, we should be able to modify that by actually activating sympathoadrenergic mechanisms. And I'll get back to that a little bit because it's a trick of actually what type of sympathoadrenergic mechanism are you looking at. So you can address that by doing the following scheme, which we did in this study many years ago. Look at baseline flow, a baseline situation, looking at the PAT signal in the periphery, and then upstream in the brachial artery infusion, you start infusing phentolamine, which is an alpha blocker. And this alpha blocker phentolamine will block autonomic signaling into the vascular bed, and we give this in steadily increasing dose levels, as you see, over a paradigm of some 140 minutes. And if you do that, and I opted to do that here in practical terms, and this is now a patient who is sleeping and at the same time receiving the infusion, and we have three different conditions here. We have a baseline condition to the left, we have a low dose phentolamine in the middle, and we have a high dose phentolamine to the right. What's happening here are actually physiological apneas that come and go. As you can see, you recognize many of these. And in parallel to these, if we have a baseline condition, we have this PAT attenuation. So we have vasoconstriction in the vascular bed, which is eliminated in part by this higher dosage of phentolamine, or almost completely by the highest dose. Which means that if you just block this system, or almost all of it, in the functional dynamic sense, is related to autonomic signaling. I won't go to all the details of this slide, but it's now showing that we can apply this, as I just alluded to, in sleep medicine. So if we're looking, for instance, which is here by the Baltimore group, looking at airflow changes, we have part restriction of the airflow, complete apnea, or complete apnea with arousal. You can see that we have a gradually increase in the attenuation of the signal. And especially in this condition over here with apnea in combination with arousal, there is a particular attenuation or constriction of the vascular bed. Same thing if you go for other forms of arousal, such as in this data set, which is presented by one of the common speakers, Pilar, there is an association between PLM-induced arousals in different settings. So we certainly have this applicability of it. The notion here that I just want to talk about and just mention before we leave it is that when we look at these autonomic signals, it's a certain type of complexity because the autonomic nervous system is not homogeneous throughout the body. So we would, for instance, expect that if we look at this signal and look at cardiac sympathetics, the signaling would be different. If we were looking at renal sympathetics, we would have a different signal. If we look, as we did in this particular setting, you look at muscle sympathetic activity, which goes to the main muscle vascular bed, the signaling in sleep apnea is different from what it is if you look at the skin sympathetics, which is what you actually reflect with this PAT technique. And I think that's important to remember, that if you see an attenuation in the PAT signal, it does not necessarily mean that the whole system is reading the same signal. It may be unique to the skin sympathetics. And the skin sympathetics is unique in the sense that it's very responsive to state changes or arousals. It's by far the most sensitive system in that context. Now, can we use this, if it has so much to do with arousability, can we use it to detect and classify sleep? Well, then we move up in the order. I think this is a latter model of the WatchPAT. It's now being very portable. Combines signals from actigraphy, saturation, and the amplitude signal and the derived pulse rate signal. And one thing that was early, I guess, recognized, was one also published by Perez Levy at the time, is that if you start looking at the REM sleep conditions, for instance, there seems to be a sustained PAT attenuation, and this was one of the images that Perez early published on this. And again, you can see the PAT signal over to the left, and then there is suddenly a shift in the signal. There is an attenuation of the signal amplitude. You can see there's some variability of the signaling in here, and then there's a resetting of the signal to higher amplitude again. If we compare this, if we then just label REM by EEG activity, as in here, we have a REM episode which coincides quite nicely with attenuation and variability of the signal. There's the motion artifact, but there's an interesting aspect which was seen in many contexts early on, is that there seems to be this attenuation of the PAT signal already preceding the EEG recordable signal in REM, which is quite interesting. It really starts asking the question, what exactly are we looking at, and usability of that. And then, so this was then used, this information, and if you can then use your signaling, for instance, like actigraphy to differentiate by sleep and wake, and on the information that you would have on REM, and also looking at the other built-in information like the pulse rate signal, for instance, during REM sleep, you suddenly have a bit more of a sleep detector. And that is what's shown in this slide. So if you now combine information from the PAT signal, pulse rate signals, there has been an attempt then to differentiate between non-REM at the left and REM sleep to start with, and also between light and deep non-REM sleep to the left. And this is really what has then, in the continued process of this being developed, as you actually you assess a pseudo polysomnogram from the single finger PAT signal. So then, a very short question before I move into the documentation of that towards the end. Is there an application to have that in polygraphic recordings? The question is, if we do polygraphy in the ambulatory setting, can we increase the accuracy of that recording by having information on sleep built in the machine? And to answer that, I will turn to another material, which is a large European study. We have ongoing the ISADA database, where we collect data from lots of sleep data from many, many patients. At present, we have some 17,000 patients in this database. And to jump the numbers, I could say in this context, this material is interesting because it reflects a little bit about the habits of sleep studies around in Europe. And if we look at all these different cities reporting in the ISADA data set, we can see that the proportion of polysomnography recording is varying dramatically between the centers. And that's these gray bars shown down here. So these centers, for instance, shown at the bottom here, almost 100% of all recordings made in the sleep labs are full PSGs. And if you move across this way, you can see that in these labs over at this end, there are almost no PSGs done. And all that sleep diagnostics is being done by polygraphy. And if you start looking at the geography of these places, you can see that this is pretty much north, and this is pretty much south. So we have a north-southern distribution of sleep studies in Europe, where a lot of PGs or ambulatory studies are made in the north, polysomnography in the south. And we have no reason to believe that the patients are really different at these stages. This is just a difference in practice. And we noticed quite early that if you look, for instance, at severity of sleep apnea, as we show in these classes, these are just percent distribution of the population in these different severity classes of sleep apnea. You can see that if we compare with the PSG data, we have this gradual increase in prevalence, at least we have sort of a linearity. If we look at polygraphy-derived reports, we don't have that. So there is something massively different between the PSG and the PG recordings in this setting, and what's that? You can also illustrate that by looking, for instance, what is the AHI derived by a PSG in the material or an AHI derived by a PG. Compare this to what is an ODI derived by PSG or an ODI derived by PG. So the differences in here, we have been sort of looking into that and dwelling into that a little bit further. And there are, of course, three potential explanations for this difference. One is that the definition in here is based on arousal plus flow reduction in the PSG, so we don't pick that up in PG, and indeed, this is probably one of the strongest factors explaining the difference. But there is also a dilution of an AHI value by inclusion of wake time in the PG, and that's really what we're after in the ambulatory recordings. So if we can do these sleep studies, we could make a partial correction of this part. And of course, there could be different populations, which we don't think is all that much of a strong explanation in this particular case. So moving towards the end, we certainly need this type of a technique, or it's very useful because it will increase the accuracy of our ambulatory recordings. Now, has this been validated for sleep detection? And there are some validation studies, well, there are actually many. Some of them are made by a slightly older model of this device. And I'm referring to one of them, which is a multi-centric study, which we in part were involved with, together with people from Haifa and Boston. It's a reasonably large-scale study. It's about 200 plus patients, and the upside of these recordings, the validations, is that we have simultaneous same-night PSG and WatchPAT recordings. And we do epoch by epoch comparison of sleep staging in these studies to see exactly how valid is this technique. And I can show you just some slides very quickly on this, and I think the message is about the same. Yes, the agreement is quite substantial. For instance, you can look at this in the sense that in these populations we frequently, of course, have a lot of sleep apnea. And if we look at the agreement of the sleep-wake determination by severity, so in normals, in mild, moderate, and severe sleep apnea patients, it's reasonably strong. You have a little bit of a diffusion over here in severe sleep apnea. The algorithm seems to be a little bit weaker or less specific. Sensitivity, specificity, and agreement numbers are being given down here to the right. If you look at the sleep-wake staging, it's probably hard to see for some of you at the back. If we look at sleep efficiency, total sleep time, sleep latency in these Bland-Altman plots, you can see that we have mean values and variability going down this range, and just an overall judgment of that would be, yes, they look pretty good, or reasonably well. And if we validate the algorithm of the VP algorithm versus sleep in the agreement between these two, the agreement for detecting light deep sleep was in close to 90%, agreement for detecting REM sleep close to 90%, and also for these other factors down at the end. So it looks pretty promising in that sense. So now sleep seems to be working. Do we then, is it then useful for sleep apnea detection and classification? Well, it's a smaller sub-study of the previous project. I won't show a whole lot of studies of that. I will use the same type of Bland-Altman plot here showing the difference between the techniques along with the size of the severity of the disorder. And you can see that these are reasonable numbers also in the receiver operating curve of this. And as I said, there have been many studies in this, and this is a listing from a quite recent meta-analytic approach to look at the validity in all these studies. And they are reasonably sized, and we're sort of collecting more and more data. And I would say that overall, the agreement between these studies there is high and saying essentially the same thing. This is quite a valid instrument. So my conclusions would then be that the PAT amplitude changes, they reflect the digital sympathetic autonomic activity, which is mediated by adrenergic alpha receptors. So in that sense, it's a unique signal, which is quite useful to look at all state changes, which also means that the technique can be used for sleep structure assessment with, I would say, probably reasonable accuracy. I think that's probably the correct way to express it. And a portable PAT device can be applied for detection of sleep disorder breathing in the home setting. Well, that's certainly working, at least in some practices. So with that, I thank you very much, and I will take questions. Thanks.
Thank you, Jan, for this very, very nice overview of the topic. So are there any questions from the audience? Maybe the first question. So, to which degree do you usually underestimate the RDI by portable or ambulatory devices? Do you have a guess?
Well, judging from those numbers that we would have in the SADA trial, I would say that maybe you have around 20%, something in that order of magnitude, maybe a bit more or maybe a bit less, but which is sizable, I think, if you start looking at the numbers and the impact it would have. So I guess the point is in there that we make very few adjustments for these differences in practice that we have in different places. And yet I think we apply this for medical legal decisions, for instance, decisions on when is treatment given, although we may be giving treatment to different patients, depending on the technique and sample. Thomas.
You made a remark that vascular effects of sympathetic tone are more on the skin level than on organ level, or how would you?
No, I guess my point is that if you look at the skin sympathetics, it's uniquely sensitive to arousal changes or state changes in sleep, and that's why I think it makes it so suitable for sleep-wake detection. It's, I can give you a good example. I'm not sure if there's anyone in this room that has ever been doing muscle nerve sympathetic recordings, which you typically would do by a needle in your fibular nerve on the leg. It's a well-established technique. And when you apply that needle, you can actually, you read the signal directly from the nerve, and you put it through a loudspeaker, and you can hear this dup, 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 as the nerve is firing. And then you can place the needle into one, and I remember sitting listening to that needle. You could go up next to the patient or the subject line there, you just do a clap like that close to the ear, which will give you an arousal signal. And if it then goes, you're in the skin sympathetic nerve fiber. And then if you push the needle a little bit further, you will go into muscle sympathetic nerve fiber, and it will not react to the arousing stimulus any longer. So in the same nerve trunk, we have fibers that are highly specialized to whether they go to the muscle vascular bed or the skin vascular bed. Quite a fascinating system, actually.
So why does the skin react to arousal and muscle not?
I don't know. Actually, I don't know what the basic defense mechanism. It's like if you watch this horror movie and then suddenly you know that someone comes into the room, you can feel the skin on your back. It's a skin reaction. It's a fear reaction. It's a skin reaction because it's a skin sympathetic that's suddenly reacting. But the physiological meaning, I'm not quite sure. Maybe that's not good suggestions to that.
I just remarked, I think during genres shows very nice recording of skin sympathetic activity during sleep apnea events.
Yeah.
To support what you say.
Yeah.
I have a sort of philosophical question to you that I couldn't figure out, and as an expert of the autonomic system, maybe you can. So you showed, and we all see the data and the meta-analysis data, agreement of about 90%. But I asked if you have a clue, or what do you think about those 9, 10, 15% that are disagree between the polysomnography and the WatchPAT. And I'm asking you if you think that they have a different autonomic system or different response to arousals, or what do you think in those cases there is disagreement? I don't know if you have the data or
no, I don't. I thought about it, and I'm not sure I have an answer really. And maybe you have it. you know, there's something in it, and I'm particularly intrigued by these factors that, I mean, to start with, we're not measuring exactly the same thing. We're measuring something else, and maybe it is interesting to measure this else, because maybe it's even a better predictor for whatever we're interested in, the classic polysomnography, who knows? You know, and maybe it's a more accurate measure of REM fragmentation, or REM shortening, or latencies, or whatever measure.
Maybe the definition is not accuracy, but relevancy.
Yeah. But it's a tough scientific issue to approach. I mean, how exactly do you approach this? And still very interesting, as always with new signals.
You mentioned that the arousal signal induces or changes the tone of the arteries, and that's what measured. So can you differentiate between central obstructive sleep apnea events?
I guess you should, actually. If you build an algorithm to do that, I'm sure there should be a possibility. Maybe someone else who wants to. You guys have a lot more insight than I do on that, whatever is being developed. But
yes, we looked at it, and I'm from Itamar Medical, and the chief scientist of the company. And what we very nicely showed that the upstroke of the signal is very different in obstructive sleep apnea versus central sleep apnea, probably due to the intrathoracic pressure, that modulates the signal.
But the specificity and sensitivity remains to be shown, I guess.
There's a question from the microphone.
Thank you for this very interesting talk. Well, quite a lot of people having sleep apnea have also hypertension are treated with agents or with drugs that influence the sympathetic tone, for instance, cardinol or hydralazine, or even the calcium antagonists that cause peripheral edema. Did you check this, or did you study this?
So it was something that was raised very early on in the development, of course, because it was interesting. And not only that, I think factors like temperature, smoking, nicotine changes, if you have vascular renal phenomena, for instance, and lots of factors could influence this. And among them, of course, drugs. And then we start looking at that. It's a little bit depending on the practice you would use in hypertension treatment, but particularly alpha blockers, I guess. They are used more in some countries than in others. Potentially beta blockers could be of interest. And you could argue that calcium channel blockers could modify this as well, maybe going another way. And I think when we looked at it, and I think it was in the limitations early on of the use of this technique, although I would say we were not extremely impressed by the size of the effects. And I didn't show this here, but we did a study looking at doxycycline as a marker for sympathetic long-term alpha blockade in treatment. And the differences in the absolute response here to arousal are actually quite small. You can detect them, significantly detect them, but they are quite small. So,
I think we will move on. Thank you very much once again for this wonderful talk, Jan. So we all know that standard diagnostic tool for diagnosing obstructive sleep apnea is polysomnography, and it's more and more important to have ambulatory devices for early diagnosis due to waiting lists and for resources and convenience. And the next talk will be by Jura Pilar. He's from Haifa in Israel. He's a sleep specialist. He works at the Canada Medical Center. And he will talk about transition to at-home OSA diagnosis, the test case of a large health provider system. So we are interested.
Thank you very much, and I wish to thank for the invitation. And I would like to, from the top scientific talk of Jan, to go down to practical clinical data of using the WatchPAT specifically, but also home sleep testing in general. And I would share with you the data that we collected in Israel. So I'm coming from Haifa, which is a sort of relatively small, 500,000, 600,000 population here on the Mediterranean. And this is our faculty of medicine and the hospital, all of this area, right on the sea, very, very beautiful place. Hard to work when you have such a beautiful view outside of the window. So I would like to start by reviewing the timeline of the changes from in-lab polysomnography to home sleep testing, and more or less, and I'll focus on the United States. I do have some data on Europe, because you probably know even better than me, but it all, I think, well, for decades, as I said, the standard test for potential for diagnosing sleep apnea was in-lab polysomnography. Then healthcare systems started to move by themselves because of cost effectiveness to do home testing, and it started by Kaiser Permanente and the VA system, which are very large systems in the United States, and it started somewhere in 2006, 2007. Then there was a big step toward home sleep testing when the Center for Medicare Services, the CMS, approved the use of home sleep testing for the diagnosis of sleep apnea. So that made a huge step forward, although they didn't require that studies will be done in the home, but they approved them. Then a couple of years later, at 2011, many private insurances started to reimburse for home sleep testing, and actually today they demand that tests will be done in the home, and you have to explain why you want to do a study in the lab and not in the home, and it includes the Blue Cross Blue Shield, the Harvard Pilgrim, the Tufts, and some others. And in the 2012, a couple of years ago, the United Healthcare, which is the largest payer in the United States, they decided that they reimburse for home sleep testing without prior authorization. So anyone who wants to perform a sleep study for a patient with suspected sleep apnea can do it in the home, but if they want to do it in the lab, they have to justify it and to get authorization by the payer. There are three large scale studies that tested the effect and the cost effectiveness of ambulatory versus in-lab diagnosis and CPAP titration. And I will get to discuss them after I present our own results, but I'll get back to these studies. So now moving to our system in Israel. There are 4 payers in Israel, the largest of which is Clalit, where I work. They insure about half of a little bit more, about 55% of the Israeli population. It's more than 4 million insured people. And the Clalit Health Services made a decision during 2009 to switch and also to reimburse for studies in the home, and to do studies in the lab only when necessary. So you have to explain why you do a study in the lab, and the regular pathway of a regular patient with suspected sleep apnea will be studied in the home. So what we wanted to do is to test the effect of this change. 2009 was sort of a transition year. So we compared, it's all computerized, all the data is very well kept, and we compared the data from 2007 and 7 or 2008, where over 90% of the sleep studies were done in the lab, and this is what you have, Jan, in your slide there. And we compared it to 2010 to 11, where the data shows that about 80% of the studies were done in the home. What are the studies done with? About 75 to 80% of the home sleep testing are performed with the WatchPAT. About 15% of the studies are performed with SomnoCheck. This is of Wyman, and about 5% are done with other systems like the Somnomedics and the Embleta. So So you have seen this already, and I'm not going to repeat it, and Jan discussed it very well. The concept is different with the WatchPAT. We do not measure directly the respiratory problem, but indirectly due to the alpha sympathetic activation. So, as Jan already showed, there are many papers that validated this system, both the respiratory indices and the sleep staging, and Jan have discussed with us some of them. As you can see, there are many of them, and you already seen also this meta-analysis that show that in general there is a pretty good agreement between the polysomnography and the WatchPAT in diagnosing the sleep apnea. So what we wanted to do is to assess the effect of the transition to home sleep testing on both the accessibility to studies, on the waiting time, on the patient satisfaction with the process, and of the cost. And also we tried to look at the short-term outcome, which we defined as CPAP purchase. We didn't include in this study CPAP usage or compliance, but we looked at least at the CPAP purchase. So what we did is we took the data of sleep studies, of CPAP purchase, and of waiting times. All were collected retrospectively from the computerized database of Clalit Health Services. As I said, everything is documented in our every patient meeting, every clinic is documented in the system with the date and what was done. So we looked at the time from the order of a sleep study to the time that it was performed, and this is what we call the waiting time. And we looked at the number of studies based on these computerized data and the CPAP purchase. Satisfaction was not documented regularly, so we did a small sample, a randomized sample of patients who did studies in the lab in 2007 or 2008, and in comparison to patients who did the studies in the home. Now there is a recollection bias here, absolutely, because some people cannot recall what happened 5 or 6 years ago, but this is a small sample just to look for satisfaction. And all comparisons were made between 2007 to 8 and 2010 to 11, and we did it, or here in this sample that I'm going to show you, it's only the Haifa district of Clalit and not nationally, although we are doing it now, we're collecting data nationally. So first of all, the number of sleep studies, it almost doubled. So the annual, again, in the Haifa district, the annual number of sleep studies, again, per 650,000 population was 735 sleep studies per year. And after the transition to home sleep studies, look, it almost doubled. So it was almost 1,400. So definitely the accessibility dramatically increased. What about the waiting time? So from the time that the sleep study was ordered to the time that it was performed, during 2007 to 8, the waiting time on the average was 9.9 weeks, almost or 2.5 months, as opposed to 1 week in 2010 to 11. So the waiting time dramatically decreased. And interestingly, it's not only the waiting time to the ambulatory study, but because so many studies were done in the home, so the waiting time to polysomnography also dramatically decreased, and the waiting time for polysomnography in Israel is now about 1 week, just as it is for home sleep testing. Then what about CPAPs? So the CPAP purchase increased from almost 600 to 830, so about 40 or 50% increase. Patient satisfaction was similarly between the two systems, so there was no statistical differences, and the satisfaction was high with both in-lab and in-home. There was slightly preference for home sleep testing something, but it wasn't statistically significant, again, based on a telephone questionnaire, and with keeping in our mind that there is a recollection bias here. And very interestingly, despite the fact that we almost doubled the number of tests, the total direct cost or the direct expenses for diagnosis of sleep apnea, so only the cost of the studies themselves, without taking into consideration that with more treated people, the healthcare utilization decreases, and it has been shown by many others that when patients with sleep apnea are treated, there is a reduction of healthcare utilization. So only if we take the direct cost, it was decreased by something like 20%, despite the increase in the sleep studies. So the conclusions from that part, or from this study, were that switching to ambulatory diagnosis improved the test accessibility, almost doubled the number of studies, significantly reduced the waiting times, patients' satisfaction remained similarly high, and the total number of CPAP purchased by the patient increased in a smaller proportion relative to the increase in studies. That means that we are studying more people with suspected sleep apnea who turns out to be simple snorers or without sleep apnea. Because we have increased accessibility, we can study also patients with a lower pre-test probability for sleep apnea. And the total direct cost of sleep apnea diagnosis was reduced about 20%. So now, in the light of our results, I want to discuss the three major studies that tested the outcomes of ambulatory versus in-lab studies. So we'll start with the study by Richard Berry at 2008, then Sam Kuna, and then Rosen. So first, this is the study by Richard Berry in Gainesville, Florida, in the VA system. They had 106 patients. They randomly selected them for one of two arms. One arm was in-lab arm, so they did a diagnostic test in the lab and then CPAP titration in the lab. And the second arm was home arm, so they did a WatchPAT study in the home and then an auto CPAP titration in the home. And let me share with you the results. First of all, this is the population. This is the portable monitoring and automatic PAT in the home, and this is the PSG arm. They had 53 patients in each. Age was similar, body mass index was similar, male to female ratio similar, and the Epworth was similar, and you can see, and the severity was also similar, with slightly more severe patients turned out in the randomization of the lab arm versus the home arm. This is the results of CPAP adherence after 3 months. This is with those who were in the portable monitoring arm, and this is those in the in-lab arm. If we put the cutoff at 4 hours per night, so above this considered better, but you can see that it's comparable. And this is the table from that paper. You can see that the number of CPAPs were more or less similar, both in numbers, 40 versus 39, and the percent of nights with usage of more than 4 hours was slightly better in the portable monitoring arm than in the PSG arm. So they concluded that it's comparable. It's not worse in terms of outcome if the diagnosis and the CPAP titration was performed in the home. Second study that I want to share with you is by Sam Kuna, very, very similar, published in the Blue Journal in 2011. And again, very similar technique, but they didn't use the WatchPAT, they used the Embleta as their ambulatory arm, but still, same method of ambulatory arm by Embleta and then auto-PAP titration in the home, and polysomnography in the lab and CPAP titration in the lab. Here's the randomization. You can see 140 patients in each arm, and very, very similar methodology as the previous study. let me show you the results. And then just go to see the CPAP compliance again after 3 months of usage. So they found that the average in those who were studied in the home and did CPAP titration, auto-PAP titration in the home, was on the average 3.5 hours of compliance, of adherence with CPAP per night, as opposed to 2.9 hours, or less than 3 hours in those who did the in-lab arm. These are the results. This is the figure from that paper. So again, we put the threshold line at 4 hours, and these are the data for the in-lab arm, and these are the data for the home arm. And you can see that actually it was slightly worse with the in-lab diagnosis and the CPAP titration in the lab. You can see that more patients had zero compliance. About 25% of the patients in the lab arm did not use CPAP, as opposed to only 50% in this arm. And when you look at those who used it for 4 hours or more, it was slightly better with the home arm than with the lab arm. And last study that I want to share with you is probably the largest study of outcome measures with portable monitoring. This is a multi-center study led by Carol Rosen and Susan Redline, published in Sleep in 2012. And again, very, very similar methodology. They had a lab arm with, again, polysomnography as a diagnostic and CPAP titration as a therapeutic, as opposed to everything done in the home, diagnosis and auto-PAP titration. Here are the numbers. So this is the randomization. The lab arm and the home arm, they had almost 200 patients in each arm, and you can see that most of the things are comparable. So the age was similar, and the gender differences in race, and the Epworth score and body mass index, they were also, it was a good randomization. And let's see the results. So first of all, as we showed, they also showed that there was an advantage in the duration of the process. So they looked at the duration of all the process. So from the point that the patient was ordered the sleep study or was suspected with sleep apnea up to the point that he received the CPAP and was treated in his home. 33 days in the home arm, 38 days in the lab arm. In our results, it was substantially more shorter with the in-home or home arm, but 5 days is also something. Then they show advantage in usage, which is the outcome. So what you see here, this is the lab arm, this is the home arm. They evaluated it both at 1 month and at 3 months. So at 1 month, the differences weren't so dramatic, or were at least comparable, not statistically significant. But look what happened after 3 months. I can't see it from there, but the usage, you can see that in those who were studied in the lab, it was 219 minutes per night, as opposed to 281. So those in the lab arm and the CPAP titration in the lab improved by more than an hour. They used CPAP for more than an hour, and also when you look at the number of patients who used it for more than 4 hours, this is what you see here. So there is a dramatic increase from 39 to 50% of people. So the outcome by CPAP usage seems to be better in the lab arms and in the home arms. And finally, the cost. So they also estimated the cost of the whole process in the home and in the lab, and they showed that the process in the lab was about 45 to 50% more expensive. So they concluded also that it's at least comparable in terms of outcome of usage of treatment, but it was dramatically better in cost and slightly better in the duration of the process. So to conclude my talk, I showed you some data, the WatchPAT, and also Jan showed it, may be used for both sleep staging and sleep apnea assessment. Many validation papers, including the meta-analysis that we showed, both of us, show that the accuracy in quantifying sleep disordered breathing is in the 90% range, and sleep staging is in the 70 or maybe a little bit more percent range. And the switch to home sleep testing in our system of Clalit Health Services resulted in increased accessibility, reduced waiting times, comparable satisfaction and treatment, and reduced cost. And this is acceptable. All four validation or all four outcome studies that were performed showed basically the same data. And thank you very much.
Thank you for these interesting data. From your point of view, what do you think? Which patients should go to sleep lab and which patients should have home sleep testing?
So, as Jan already said, first of all, regular patients, none of the patients are regular, but let's say patients with a high pretest probability, in a stable condition, I think should be studied in the home. In patients that there are medical problems, or they are unstable, they need a hospital environment, or there are contraindications for home sleep testing for various reasons. For example, for the WatchPAT, it could be pacemakers, for example, or stuff like that. So you need to pick those who cannot do ambulatory study. But I accept the concept that the general approach or the first choice should be study in the home, and if there is a contraindication or something unique that this cannot be performed, so they need to be tested in the lab. And this is what we do in our clinic.
Okay.
So you nicely showed that the cost of diagnosis decreased, even if there is an increase in number of patients. But what we are concerned about is the cost of the sector. So if you include treatment and all the long term to get more patients, so what about the cost of the sector of sleep medicine before the change and after?
Okay, so I mentioned this, but I will now expand on this. I don't have this data, although we intend to look at this, and the question was raised by the payers. I mean, we buy more CPAPs, patients took more CPAPs, so this is on one side presumably increases cost, but on the other hand there are many studies, or not so many, but also not so few, that show that with good treatment the healthcare utilization and the complications are reduced. So you eventually should save money, even taking the consideration that you sell more CPAPs. But I don't have this data, so I can't discuss it. Yes, please.
Good job. Thank you for your interesting data. Let me confuse them on the CPAP usage time. What is your conclusion concerning the difference between the in-lab results and the ambulatory results? Is this how you prepare the patient to use it, or is it the WatchPAT, or it?
I don't have a good explanation for this, and that's why I try to say that it's not that the home lab is not the advantages in terms of CPAP usage, although the data show that it is, but at least it's not a disadvantage. I don't know why those people who used CPAP in the home, CPAP titration in the home, used it more after 3 months as opposed to those who used it in the lab. You can think of potential explanations, but I don't know that any of them is really correct, and I'm open for suggestions here. Potentially it could be that when you do it in the lab, the titration is less accurate, or slightly worse, or I don't know, but I don't have a good explanation for this. I just show the data, and I'm open for good explanations if anyone has.
There's another question.
Yes,
from
I would like to come back to CPAP titration. What do you think, how high is the percentage of those people who need in-hospital CPAP titration? Do you have any data?
In our,
concerning
well,
contraindications
yeah.
and so on?
Well, yes, we do have that data, and actually when I showed the data that currently we are doing about 80% of the studies in the home and 20% of the studies for sleep apnea in the lab. For CPAP titration, it's about 98% in the home, and very few CPAP titrations we are doing in the lab, and I think that the AutoPAP is as good as most of the data show you. There are a couple of papers that I can recall that show that titration may be better by a technician, but I think, this is my personal experience, and I don't have data to show you, that the CPAP titration in the home, AutoPAP, is as good as in the lab.
And concerning patients at risk.
Well, if a patient suffers from severe congestive heart failure and needs to be in a hospital environment, definitely he will titrate CPAP in the hospital, and we do that. But what is the percentage, what is the portion of these patients compared to the general? I think this is small part of the patients that are in stable condition, that they need CPAP titration in the labs.